Thank you, Liz, and thank you to all the previous speakers. Thank you to Anne Weldon for that wonderful welcome to country. I would like to acknowledge that we are meeting on Gadigal land and the traditional custodians, the Eora Nation. I'd like to pay my respects to all of the Aboriginal colleagues here in the room today. It's been a privilege working with you for many years. We've got two parts to this presentation. One is interactive and probably a bit more interesting, but I'll get through a few basic bits to give you an overview of the outreach program so you have a baseline of understanding. You all come from so many different parts of the program. If you didn't know, the room is roughly 50% health administrators like me and 50% outreach clinicians that regularly and routinely visit outreach sites across New South Wales and the ACT. So we have a real rich group here, and I look forward to hearing from you throughout the day. I hope we will have some time for discussion as part of the Kahoot game we'll play a bit later. It was very popular last year. Big green button, yeah? So this is the outline. So fundamentally, the outreach program is designed to increase access to services for people in rural and regional areas and Aboriginal communities. How it does this specifically, its role in the access piece is to remove a number of barriers that otherwise present themselves. And obviously for rural people, that's distance and the cost and expense of traveling to outreach to a clinic, and the inconvenience, the impact that has on your life and your family if you're a carer or a parent. Costs and other economic hurdles around private services that often will charge a fee, particularly in the specialist and allied health space. It also is a significant barrier for people and does reduce access. It's empirically measured that it does do that. And then cultural safety barriers, which is also a very significant barrier. You know better than I, for a lot of Aboriginal people, even if the service is a public service or it is around the corner, an Aboriginal person may or may not access that service if they don't feel is culturally safe, or they have to overcome any cultural safety concerns they have in order to achieve that. And that does cause a barrier, and that reduces access, and it impacts health. Finally, an important element of outreach that is sometimes just a flow-on effect from visiting clinicians working with local clinicians is the exchange of skills that occurs. Both exchange of skills from a visiting specialist or allied health practitioner to the local primary care team, but also the skills that local primary health team and Aboriginal health workers working in that team transfer onto the specialists who then work in other communities. So it's a symbiotic skills exchange. And that's feedback we get from both sides of the piece. These are the programs. Rhonda went through them, so I won't labor them. But that's a good resource if you want to know what the programs do, eligibility criteria. They're all funded till 2020, June 2020, with the exception of the Healthy Years program that's just recently been funded until 2022. So the outreach story really is a story of growth and maturity. So it has been around for a long, long time. As Rhonda said, RDN's been involved in administering outreach since 2001. When it was the old MSEP program. But we've compared, say, the last funding cycle and the current funding cycle to look at trends. And between 2013 to 2016, there was very significant growth in the program. New chronic disease outreach programs will be rolled out. The Healthy Years program were being rolled out. And we worked together, local services, health practitioners, and health administrators, to build services, identify needs, review them, improve them. A lot of that growth came from not only new funding, but using funding better. The services cost less now per clinic hour than they did on the first day of that, on the first quarter of 2013. So we have really improved a lot of efficiency, and those savings have been reinvested into new services, and that's driven a lot of growth. So that chart on the right-hand side, you can see a lot of the indicators have actually doubled with more or less the same amount of resources, and that's quite a significant achievement that we can share together. The maturity bit is the sort of flat line you see for the last 2 years. Now we're still working at unprecedented levels of activity. There's about 200,000 occasions of service a year, which means at any one day, there's about 700 occasions of service, and about 400 of them are being accessed by Aboriginal people. So that is quite a lot of activity. But we're kind of stretched in terms of the resources and how far they can fund new services. And the challenge for us really is to see how we can continue to increase access and ensure that those services are as impactful as possible, acknowledging that we probably are going to be funding this level of clinic hours for the remainder of the funding cycle. It is good to hear that we might get some audiology and diagnostic outreach funding as well, which would certainly complement the ear health space and is certainly very needed. So key program stats, I already talked about the volumes of patients that come through the program, almost 1 million occasions of service. Give us one more year and it'll be 1 million occasions of service since 2013. Almost 170 towns receive outreach services. That includes a number of urban Aboriginal communities. There's 800 outreach, more than 800 outreach clinicians that work in the program. So that is a very large workforce and a very key part of the rural health and Aboriginal health workforce. So you are a very key part of that. And some remote communities will never have a full-time cardiologist or a full-time dietitian or nurse practitioner. And outreach is the solution that they can have access close to where they live. If you added up all those hours that those 800 clinicians work, it's almost 90 full-time equivalent health practitioners. But they represent 37 medical specialist disciplines, and those are actually categories of disciplines. There's lots of subspecialties of pediatricians and general physicians and other things, and another 27 allied health, nursing, and Aboriginal health practitioners. Those are the disciplines that they represent, and that just demonstrates the breadth of need in rural communities and how we've worked together to identify what those needs are and respond to them. 200 health administrators is very conservative. There's a lot of people involved in that program, but there's definitely a core group that we are working with on a daily, weekly basis, right from working with Martin and Rhonda and their teams in the department to working with accountants and people that report data in ACHs and LHDs and other NGOs that we work with. And those are the 60 partner organizations that we directly contract. Kate and others alluded to the need. This is the results of our latest annual review. More than 370 new outreach service gaps have been identified through that latest round of reviews. Unfortunately, we aren't in a position to actually respond to many of them. The challenge for us really is to look at the priority of services we are funding and work with you to identify whether those are continuing priorities and massage around the edges of the program to respond to the most pressing needs. If you look at what those needs are, there's quite a distribution across the normal outreach disciplines that are funded. Not surprisingly, GPs working in a chronic disease context, psychiatrists, respiratory physicians, and pediatricians are on the highest priority in terms of clinic hours that are being requested. Interestingly, that's consistent with the services that we already do fund, with the exception of respiratory. That's kind of floated to the top. Across the state, these are the allied health and nursing outreach types of services that have been requested and are identified as gaps. It's quite a spread. Again, nurses is a broad category for a lot of subspecialties, often would be working in a chronic disease clinic. Aboriginal health workers, it shows the importance of Aboriginal health workers that are attached to almost every service that is responding to an Aboriginal health community need. Speech pathology has been requested. Generally, pediatrics and child health and early child health have been raised as significant needs, along with mental health and chronic disease. I would say that those are three areas of health that are constantly raised. And there you go, psychologists, OTs, and physios are amongst the highest. You can have copies of these slides later if you can't see the text. So strategic themes. As I said, the biggest challenge for us is how do we respond to these needs? How to respond to these needs with the sort of resources that we have. And some of the feedback that we've gotten from you and from our working group and advisory forum is to work with our regional stakeholders to identify what the solutions might be. It may not be an outreach solution or an RDN-funded solution, but there are other stakeholders in the state government, HS sector, primary healthcare networks, where we can actually look at these priorities and see if we can integrate some of responding to those with some of those other services. Value for money will always be a theme. We will always continue to chase savings and see if we might be able to reinvest those to support another priority need. And we work very closely with the local subcontractors and regional outreach groups to do that. Aboriginal cultural safety is absolutely imperative. There's no point in having a service being delivered if it's not culturally safe. We have specifically discussed that with each of the services that we work with and at regional meetings and gotten some valuable feedback on how to improve that. By and large, it's done quite well, but there are some gaps that we need to close to ensure that all health practitioners are aware that they're working in Aboriginal spaces and need to be providing a culturally safe service. Understanding our impact, we're very good at measuring the things that I put up there earlier around patient occasions of care and throughput. It's harder to measure impact, what impact that's having, and at this same forum last year we got some valuable feedback in a workshop on how we might do that, and I'll be very excited to show you some information on that. And telehealth, I know you've probably heard about it a lot. It's not going to be a panacea that's going to solve all of our problems, but we do think we can leverage the outreach work that's already been done with telehealth to improve access and improve impact. This is the needs assessment process that we just went through and the annual review process. Thankfully, we're at the end of it. We spend about 8 months planning for the next 12 months. It's a very significant part of what we do, but it's integral to inform the services that are being funded and make sure that they are delivering the highest priority service needs. That involves a number of surveys, both with health practitioners, of patients, a range of other stakeholders, interviews with local agencies, and we pull that all together to submit plans to the department, which were the last one was approved this morning. Thank you, Martin. So I'm very pleased to let you know that you'll be, the funding will come through the door in the next week or so in the form of a contract. But that it is a Leviathan piece of work, and I'd just like to thank everyone that's been involved in pulling that together. And now we're at the forum, we'll be able to talk about some of the results, and we'll talk about some of the survey results. So health practitioner survey, about a third, not quite a third of health practitioners responded. It's a little bit higher than last year, and they represent well the outreach practitioners working in the program. I'll have to say nurses are slightly underrepresented, and that might have something to say about how busy nurses are and their penchant for filling out surveys. But we'll look at why that is and try to improve that going forward. The patient feedback was almost doubled from the previous year, and I have to attribute that to work that people on the ground have been doing to help collect patient surveys, but also some stronger project management around doing that and being more deliberate and picking the sites to ensure that they're appropriate sites to survey. Almost 600, so more than 600 patients responded to the survey. About half of them were Aboriginal, and as we go through the Kahoot game, we'll see what some of the responses were. That's the distribution of patients access the survey. And I'll use the term Aboriginal for both Aboriginal and Torres Strait Islanders, as is the convention in New South Wales as we go through the Kahoot game. This is where the patients came from. So out of 200,000 occasions of service, it's a pretty good sample. They are reasonably well distributed across all regional, remote, and urban areas, and both Aboriginal and non-Aboriginal clinics were surveyed. So it's a pretty good sample, and we think the results are fairly reliable. This is the interactive bit. I would appreciate it if everyone could go to kahoot.it, log onto your mobiles if you want to play. There is a prize at the end for the top 3. So I appeal to your competitive natures to get involved. Yeah, so about a quarter of outreach practitioners already provide some kind of telehealth in their outreach, and this is how they describe what that is. So 80% is video conferencing, so it's your classical video outreach, but others talk about mobile tablet applications, e-health record management, and sort of another nondescript category. That's good, that's heartening, and I think that's improving and increasing. If I go to the sort of interest in telehealth and progressing it more, about a third of the practitioners, more than a third, wanted RDN to work with them to actually expand their service to include some kind of telehealth element. So we'd be working with each of the stakeholders and you as practitioners to do that if that's what you want to do. I'll confess we don't know all the answers, but I think we can work together to identify one element of your service that we can use telehealth to enhance and improve access for communities. Next question. You only have 20 seconds this time. Oh, well done. This surprised me. There's 15% of outreach patients do not use any of these devices. I wonder if 15% of people in the room don't use devices. But that's quite remarkable, and I think we have to acknowledge that there's always going to be that group of patients that will need the conventional face-to-face service. We can't rely on technology to engage them or provide services to them. If you look at the breakdown between Aboriginal patients, that is non-Aboriginal patients, not all patients, it's fairly similar, the use of technology between those two groups. There is a slight difference in tablet and desktop use. Aboriginal patients use that less. So that's, I think, important to acknowledge. We'll go to the next question. This surprised me. So vast majority of patients would rather wait to see a face-to-face clinician than to do a telehealth session. So I think that's something that's interesting to bear in mind, and I think if we think about developing telehealth services, I think we have to think about convincing patients to use it as well as convincing health practitioners. Interestingly, we did also ask patients if they had already used a telehealth service, and that slightly improved their willingness to use a telehealth session. So that dropped by about 10%. So 66% of patients would prefer to wait if they had already had a telehealth experience before. We don't know if that was a positive telehealth experience or a telehealth experience with an outreach provider, but I think there is some evidence to suggest that using the technology improves how comfortable they are with trying to use it again. And I have to say that that's your doing, you as clinicians and local service administrators. Patients are very, very happy with the outreach services they received. We do think there's a bit of positive bias in there, and some of the commentary around their responses are that they're potentially afraid to say anything negative about their service because they might lose that service. So we do ask a few more probing questions, which we'll go through in a moment, and give us a little bit more of a balanced view of how we're doing. So you can see the distribution of satisfied, very, very satisfied. The very small proportion of patients that expressed dissatisfaction was really around practitioners running late or consultations being rushed, which is, you can envisage being happening in a busy outreach clinic where the practitioner is only there for a day and you've got to get through a long list of patients. Patients do feel that outreach has improved their access to healthcare. Some are not sure. I'll have to look at why that is and get back to you. So majority of patients travel less than an hour to access an outreach service, and the average time is about half an hour, which I think in itself speaks to the importance of the outreach program, because that travel time would otherwise be very significant for most of these patients who are based in rural areas. The average time for an Aboriginal patient was 17 minutes, and the average time for a non-Aboriginal patient was 42. That reflects a number of things. There are different programs, and their services are provided in different regions. But I think it's a positive, largely, to show that services are being delivered quite close to where people live. Go to the next. There you go. So most of you got that right. So private vehicle is definitely the most frequently used form of transport to get yourself or for someone to drive you to a clinic. It includes being dropped off by a family member, but that's still a private vehicle. You can see Aboriginal patients rely on community transport more often, which probably doesn't surprise you. But I think it emphasizes the importance of those community transport services and networks for quite a large proportion of patients. So health outcomes is something that we want to understand much better. And this is it's a simple question, but it is a functional health outcome question if they feel better about their health. And it's very pleasing to see that the vast majority of them do. They feel better about their health. Those that said no change often were patients that were accessing a cancer service. And you can see that last comment on the bottom there. It can reflect that patient who may not be able to feel better about their health, but appreciates being able to access the service and the care that they receive. So this is an interesting bit of feedback from health practitioners. This is exactly the same questions that were asked in a MABEL survey. I think it was the 2016 survey that looked at the motivation of outreach providers broadly, not only on the outreach program. And this is actually inverted. The results are inverted. Outreach practitioners working in the outreach program are primarily doing it to provide healthcare to disadvantaged people and regions and to support their colleagues and to work in challenging situations. Not that wanting to expand your practice is necessarily, there's nothing wrong with that, but I think it's really appropriate that we have a workforce that's utterly committed to the patient healthcare, and I think that represents that quite well. We're almost done. People should know this. The feedback on local orientation from when the health practitioner originally started at the clinic, it's not great. It's about 50% rated as good or very good, and I think that's probably an area of the program where we need to pull up our socks and ensure that orientation happens up front. It's particularly important because that's often where the local Aboriginal cultural orientation also occurs, and that needs to happen as soon as possible when a service is delivered. So we'll continue to work with you to make sure that happens. Also very interested in your feedback on how we might be able to support you to do that. And that's the information there. About 12% indicated it didn't happen at all. So that's not good enough, and it's something we need to improve. And we'll go to the final question. And sorry, it's the penultimate question. There you go. Nice mix of results. By and large, outreach practitioners working for the program are pretty happy and will continue to work. Rather than going to the slide, we'll just go straight to the next question. Yes. Most health practitioners want to continue providing outreach for more than 3 years, and that is 85%, so that's brilliant. That's longer than we've got funding for, so at least that's sorted. When providers tell us that they intend to cease in the next 12 months, we do work with you to put a succession plan in place to make sure that's a smooth transition and there isn't any interruption to the community. Please come and talk to me or anyone from the outreach team if you want to discuss any of these things further. We have the next day and a half to network with you, and we're very interested in your feedback on all of this. Thank you very much.